Hi, welcome to our channel of ignou audiobooks, Indira Gandhi National Open University, School of Social Sciences, SOSS, Master's Degree Programs, MA in Psychology, MAP, Second Year, MPCE 0 to 1 Counselling Psychology, Block-4 Counselling for Mental Disorders, Unit-4 Eating Disorder, 4.0 Introduction. Eating is one of life's great pleasures. But some people have difficulty in controlling their food intake. Eating disorders are relatively recent additions to psychiatric classification systems. The vast majority, more than 90% of those affected with eating disorders are adolescents and young adult women. The reason for women being vulnerable to eating disorders is their tendency to go on strict diets to achieve an ideal figure. Eating disorders are sometimes symptoms of a physical ailment, but they might also be external manifestations of mental disorder. The social causes of mental disorder, the interchange between people and society, and the influence that culture has on our perceptions of reality are probably most clearly demonstrated in the mental disorders anorexia nervosa and bulimia nervosa. Many newspapers and magazines feature glamorous celebrities who devised a special diet and shed pounds to become new, healthy, more confident people. Many psychological and social theorists believe that the influx of media images of thin women, many directed at the young, is a prime cause of the massive increase in eating disorders in the Western world. In this unit, we are going to deal with eating disorders. First, we start with definition and description of eating disorders. This is followed by socio-cultural comparison of eating disorders within different parts of America and then follow it up with other countries including India. Then we present different types of eating disorders such as anorexia nervosa, bulimia nervosa, binge eating, etc. Then we deal with causes of eating disorders, in which we present biological, cultural, family, and other theories. This is followed by treatment of eating disorders and the different types of treatment. 4.1 Objectives. After completing this unit, you will be able to times define eating disorders, times describe the prevalence of this disorder, times explain the types of eating disorders, times elucidate the causes of eating disorders, and times describe the treatment for eating disorders. 4.2 Definition and description of eating disorders. Eating disorder is when a person eats or refuses to eat in order to satisfy a psychic need and not a physical need. The person does not listen to bodily signals or perhaps is not even aware of them. A normal person eats when hungry and stops eating when the body doesn't need more, when he feels the signal of satisfaction. Eating disorders are usually classified as anorexia nervosa, bulimia nervosa, and binge eating disorders in accordance with the symptoms. However, a person may have an eating disorder without belonging exactly to any of these categories. Those who lose weight because of illness, example, cancer, are not considered to have an eating disorder. Eating disorders do not seem to manifest as anorexia nervosa and bulimia in non-Western cultures like India, but occur infrequently in milder forms with fewer symptoms. In the absence of the major disorders, standard questionnaires, such as the eating attitudes test appropriate for detecting severe disorders, may not be useful in identifying low-prevalence milder disorders. Culture has been identified as one of the etiological factors leading to the development of eating disorders. Rates of these disorders appear to vary among different cultures and to change across time as cultures evolve. Additionally, eating disorders appear to be more widespread among contemporary cultural groups than was previously believed. Anorexia nervosa has been recognized as a medical disorder since the late 19th century, and there is evidence that rates of this disorder have increased significantly over the last few decades. Bulimia nervosa was only first identified in 1979, and there has been some speculation that it may represent a new disorder rather than one that was previously overlooked. Russell, 1997. However, historical accounts suggest that eating disorders may have existed for centuries, with wide variations in rates. Long before the 19th century, for example, various forms of self-starvation have been described. Bemporad, 1996. The exact forms of these disorders and apparent motivations behind the abnormal eating behaviors have varied. The fact that disordered eating behaviors have been documented throughout most of history calls into question the assertion that eating disorders are a product of current social pressures. Scrutiny of historical patterns has led to the suggestion that these behaviors have flourished during affluent periods in more egalitarian societies. Bemporad, 1997. It seems likely that the sociocultural factors that have occurred across time and across different contemporary societies play a role in the development of these disorders. 4.2.1 Sociocultural comparisons with America. Several studies have identified sociocultural factors within American society that are associated with the development of eating disorders. Traditionally, eating disorders have been associated with Caucasian upper socioeconomic groups, with a conspicuous absence of Negro patients. Rutch, 1966. However, a study by Rowland, 1970, found more lower and middle-class patients with eating disorders within a sample that consisted primarily of Italians, with a high percentage of Catholics and Jews. Rowland suggested that Jewish, Catholic, and Italian cultural origins may lead to a higher risk of developing an eating disorder due to cultural attitudes about the importance of food. More recent evidence suggests that the prevalence of anorexia nervosa among African Americans is higher than previously thought and is rising. A survey of readers of a popular African American fashion magazine, Table, found levels of abnormal eating attitudes and body dissatisfaction that were at least as high as a similar survey of Caucasian women, with a significant negative correlation between body dissatisfaction and a strong Black identity. Pumariga et al., 1994. It has been hypothesized that thinness is gaining more value within the African American culture, just as it has in the Caucasian culture. Hasu, 1987. Other American ethnic groups also may have higher levels of eating disorders than previously recognized. Pate et al., 1992. A recent study of early adolescent girls found that Hispanic and Asian American girls showed greater body dissatisfaction than white girls. Robinson et al., 1996. Furthermore, another recent study has reported levels of disordered eating attitudes among rural Appalachian adolescents that are comparable to urban rates. Miller et al. In Press. The notion that eating disorders are associated with upper socioeconomic status, SES, also has been challenged. Association between anorexia nervosa and upper SES has been poorly demonstrated, and bulimia nervosa may actually have an opposite relationship with SES. In fact, several recent studies have shown that bulimia nervosa was more common in lower SES groups. Thus, any association between wealth and eating disorders requires further study. Gard and Freeman, 1996. 4.2.2 Eating disorders in other countries outside the United States. Eating disorders have been considered to be much rarer. Across cultures, variations occur in the ideals of beauty. In many non-Western societies, plumpness is considered attractive and desirable, and may be associated with prosperity, fertility, success, and economic security. Nassar, 1988. In such cultures, eating disorders are found much less commonly than in Western nations. However, in recent years, cases have been identified in non-industrialized or premodern populations. Ritembo et al., 1992. Cultures in which female social roles are restricted appear to have lower rates of eating disorders, reminiscent of the lower rates observed during historical eras. in which women lacked choices. For example, some modern affluent Muslim societies limit the social behavior of women according to male dictates. In such societies, eating disorders are virtually unknown. This supports the notion that freedom for women, as well as affluence, are sociocultural factors that may predispose to the development of eating disorders. Cross-cultural comparisons of eating disorder cases that have been identified have yielded some important findings. In Hong Kong and India, one of the fundamental characteristics of anorexia nervosa is lacking. In these countries, anorexia is not accompanied by a fear of fatness or a desire to be thin. Instead, anorexic individuals in these countries have been reported to be motivated by the desire to fast for religious purposes or by eccentric nutritional ideas. Castello, 1997. Such religious ideation behind anorexic behavior also was found in the descriptions of saints from the Middle Ages in Western culture, when spiritual purity, rather than thinness, was the ideal. Bemporad, 1996. Thus, the fear of fatness that is required for the diagnosis of anorexia nervosa in the Diagnostic and Statistical Manual, 4th edition, American Psychiatric Association, may be a culturally dependent feature. Hasu and Lee, 1993. Anorexia nervosa has been described as a possible culture-bound syndrome, with roots in Western cultural values and conflicts. Prince, 1983. Eating disorders may, in fact, be more prevalent within various cultural groups than previously recognized, as such Western values are becoming more widely accepted. Historical and cross-cultural experiences suggest that cultural change itself may be associated with increased vulnerability to eating disorders, especially when values about physical aesthetics are involved.
Such change may occur across time within a given society, or on an individual level, as when an immigrant moves into a new culture. In addition, cultural factors such as affluence and freedom of choice for women may play a role in the development of these disorders. Bemforad, 1997. Further research of the cultural factors influencing the development of eating disorders is needed. 4.2.3 Eating disorders in India. Most people in India struggle to get enough to eat, and it is estimated that 60% of India's women are clinically malnourished. But psychiatrists in urban areas are reporting cases of anorexia nervosa, the so-called slimming disease that can cause sufferers to starve themselves to death. Most people in India have still not heard of the condition, but some psychiatrists are of the view that there is an explosion in anorexia cases over the past few years. The arrival of cable television and Western fashions and films has given today's teenagers the idea that thin is beautiful. Western fast foods have arrived too, but as the young girls at Delhi's pizza and burger bars tuck in, they also say they want to lose weight. The irony is that India's traditional idea of beauty is of healthy, well-fed women with rounded figures. One report states that there is obsession with physical appearance on rise amongst college-going crowd in India. Youngsters in the age group of 12 to 25 years are using diet pills, fat burners, fasting, resorting to self-induced vomiting etc. in order to stay slim and look attractive. They are deeply influenced by modern lifestyles together with ubiquitous show of a perfect 10 figure and airbrushed faces in advertisements and pictures of ramp models, film, sports personalities etc. in newspapers, magazines etc., says a SOCHM study. Kids as young as 12 years old are resorting to severe dieting, consuming fat burners and protein shakes, thereby developing serious eating disorders, according to the Chamber study. ASTF team conducted a survey in 10 major cities of Delhi NCR, Mumbai, Kolkata, Bangalore, Chennai, Hyderabad, Ahmedabad, Chandigarh, Jaipur and Lucknow and interacted with around 2,500 young folks, almost equal number of males and females, in the age group of 12 to 25 years. The study was carried out during October 2010 to March 2011. According to the SOCHM study, an interesting aspect that emerged out of the survey was that youngsters in urban India feel the need to diet as they aspire to be thin and beautiful as cine stars, models, celebrities and feel that they will be popular if they are able to attain that ideal body image. The study stated that today, Even the kids are not off limits from the celebrity-driven trend of staying slim to look perfect and are dieting and starving themselves to achieve desired results. This trend is equally prevalent both in males and females. This is likely to have an adverse impact on young people, especially females, as they suffer from eating disorder and psychological problems like that of a distorted body image, sense of insecurity and a low self-esteem owing to fear of rejection etc. Parents tend to overlook the strange eating habits of their growing kids without realizing that this is robbing them of their childhood. Youngsters, 12 to 25 years old, in Mumbai topped the chart with around 55% of them admitting to dieting over 3 days a week and 35% admitting to following a daily diet plan. Youth in Delhi NCR ranked second with 40% of them admitted to dieting over thrice a week and 30% said that they diet daily. Chandigarh ranked third where 25% said that they follow a strict diet regime every day and 35% said that they diet at least 3 days per week. Ahmedabad stood on the fourth rung with 30% admitting to dieting over 3 days a week and 20% said that they diet daily. Figures in Lucknow and Jaipur were almost equal as 25% in said that they diet daily whereas 15% respondents admitted to have been following a daily diet chart. Majority of respondents agreed to following severe diet regimens but were ignorant about the fact that it was affecting their growth. Besides, a SOSS study has revealed that youngsters obsessed with dieting are becoming anorexic by starving themselves relentlessly and are prone to diseases like depression, anxiety, insomnia etc. While sharing their views with the SOSS representatives, the respondents said that they feel worthless for being overweight and constantly fear of becoming obese. That's the reason they starve themselves to attain a lean look. Majority of them admitted that they exercise compulsively, often to the point of exhaustion to compensate for the calorie intake. 4.3 types of eating disorders. Although there are several different types of eating disorders, psychiatrists and psychologists generally tend to divide them into two broad categories: anorexia nervosa, bulimia nervosa and binge eating. Anorexia nervosa is a condition characterized by a refusal to maintain a minimal normal body weight, voluntary self-starvation and an intense fear of becoming fat. These individuals achieve abnormally low weight by severely dieting, fasting and often by exercising compulsively. Most cases are female coming from the upper or middle class. Bulimia nervosa is characterized by recurrent episodes of binge eating while experiencing a subjective sense of lack of control over the eating. The regular use of extreme weight compensatory methods, for example, self-induced vomiting, laxative abuse, diuretic abuse, excessive fasting and compulsive exercise, and dysfunctional beliefs about weight and shape that unduly influence self-evaluation or self-worth. 90% of the cases happen to be women. Bulimia nervosa is likely to result from a combination of genetic, familial, psychological, and sociocultural factors. Binge eating disorder is characterized by recurrent episodes of binge eating but, unlike bulimia nervosa, no extreme weight control behaviors are present. A decreasing weight goal, increasing criticism of the body, increasing social isolation, disruption of menstruation, reports of purging in the context of dieting are some of the warning signals for parents. Parents are largely responsible for shaping a child's body image and eating lifestyle. It is believed that parents who are themselves preoccupied with body image and weight increase the ranks of childhood anorexics. Parents should communicate with their children and try to maintain a healthy lifestyle at home for the sake of their children. Depression, stress and genetics are important factors when it comes to eating disorders. It has been observed that those who suffer from anorexia nervosa are usually sensitive, intelligent people who have a tendency to turn into control freaks. On the other hand, anorexia bulimia is associated with those who are very emotional. They then alternate between periods of overeating and then a self-inflicted punishment in the form of starvation. Since eating disorders usually begin in teens, parents can play an important role in curbing them. Eating disorders in children can often be a result of unhealthy eating habits at home. Parents should realize that children unconsciously follow most of their dietary habits. For this reason, parents have to be careful about their own diet and make sure that they are setting a healthy example for their kids. Second, mealtime should be fun. Painful or stressful topics should be kept away from the dinner table. This is not a time to discuss your child's bad performance in exams. Instead, make it a family bonding time. Keep conflicts away from mealtime. Parents should also try to make a healthy diet palatable. Incorporate interesting recipes so that eating becomes an enjoyable activity. A balanced diet consists of adequate amount of carbohydrates, proteins, fats and vitamins. An average Indian meal consisting of chapatis, dal, green vegetables and curd forms an ideal diet. Deviating greatly from this for more than 3 weeks would be considered as a disorder. There can be several reasons for this. First, there is tremendous peer pressure on young people to look good. Girls compete with one another to fit into a smaller size as thin as in. The pressure to look attractive is so great that they cut down blindly on the first thing that happens to be in their control, which is their food. In the absence of proper guidance, they blindly follow crash diets. Some even deprive themselves of all food. There are others who only go by calorie count, skip healthy meals and binge on junk foods. In their mind, they are not doing anything wrong as long as they do not exceed the calorie count. This lack of information about a balanced diet can lead to severe consequences.
Parents in such a situation should not coerce or nag their children. They, instead, have to lead by example. If kids see a healthy and an active lifestyle at home, they will automatically emulate it. Do not sermonize, subtle guidance is the need of the hour. Sometimes eating disorders are a result of severe emotional stress or depression. Parents have to understand their children and ensure that their emotional needs are being fulfilled. These situations have to be tackled sensitively. In case you are not able to diagnose the cause, medical help should be considered. In reality, it is difficult to differentiate between the two since there is a lot of overlap in the behavioral characteristics and psychological process of each. Many theorists suggest that people's eating habits and their perception of their own body image lie on a continuum along a scale that extends from extremely distorted eating habits and an unrealistic body image at one end to no psychological or behavioral distortions at all at the other. Everyone stands somewhere within in this range. Sometimes we see people who think they are fat and sometimes starve themselves, or who are on permanent diets. This does not necessarily mean that they have an eating disorder, but it does show how anorexia and bulimia might be extreme versions of common occurrences. 4.3.1 Anorexia nervosa. Anorexia nervosa literally means nervous loss of appetite, yet people with anorexia do not lose their appetites but are often hungry and preoccupied with food. They want to eat but seem to be starving themselves. Anorexics might even love to cook for others. They might read recipe books, prepare meals, shop for food, and even work in restaurants, but they always avoid eating any caloric, rich food themselves. They usually have a distorted body image and think they are fat when, in fact, they are wasting away, and many anorexic people try to hide their bodies in oversized clothes. 4.3.2 Diagnosis of anorexia nervosa. People are diagnosed as anorexic if they weigh less than 85% of the expected weight for their age and height in the normal circumstances. They might look extremely thin and feeble because of their significant weight loss, and they often have other health problems, including low blood pressure, constipation, dehydration, and low body temperature. 4.3.3 Diagnostic criteria for anorexia nervosa, DSM-4. Times refusal to keep body weight or above 85% of the generally recognized normal level for age and height. Times intense fear of gaining weight or becoming fat, even when underweight. Times disturbance in experience of body weight or shape. Undue influence of these factors on self-esteem or denial of the seriousness of the health risks of the current low body weight. Times if menstruation has begun. The absence of 3 consecutive menstrual cycles. 2 types of anorexia are recognized. 1. The restricting type, in which the main focus is on restricting food intake, and 2. The binge eating purging type, in which there is regular binge eating, followed by purging by vomiting, laxatives, etc. 4.3.4 Prevalence of anorexia nervosa. Anorexia nervosa occurs mainly in women. For every male sufferer, there are 15 females who have the disorder. However, there is evidence that the number of men with eating disorders is rapidly increasing. Anorexia usually starts at between 14 and 16 years, although two researchers from Great Ormond Street Children's Hospital in London, England, have reported cases of anorexia in children as young as 8-year-old. It is estimated that between 5 and 15% of people with anorexia die from it or from related disorders. 4.3.5 Bulimia nervosa. Bulimia nervosa is characterized by sporadic episodes of compulsive binge eating. People with bulimia rapidly eat lots of carbohydrate-rich foods in a seemingly uncontrolled way. They eat more than just a load of cookies. They could eat a whole of pizza, a whole tub of ice cream, several giant packs of potato chips, a whole creamy dessert, a whole quiche, or lots of fizzy or milky drinks. They usually choose foods that are soft and easy to eat. The binge usually ends with stomach pains or some kind of purging, either self-induced vomiting or defecating. As a result of taking laxatives, some people begin their binges by eating colored marker food so they will be able to tell when they have thrown up all the food they took in. Although many people describe themselves as binge eaters, it is the severity and frequency of the binge eating in bulimia that makes it such a severe disorder. In mild cases, a person might binge 2 or 3 times a week. In more extreme cases, it might occur 30 times a week. 4.3.6 Diagnostic criteria for bulimia nervosa, DSM-4. Frequently occurring episodes of binge eating that are characterized by both a. Eating an amount of food that is definitely larger than most people would eat within a specific period of time and in similar circumstances, and b. A sense of lack of control over eating during the overeating episode, times recurrent behavior to compensate for the overeating and prevent weight gain, including vomiting, laxatives, fasting or excessive exercise, times the occurrence of both the binge eating and the compensatory behaviors, at least twice a week for at least a 3-month period, times self-evaluation that is over-influenced by weight and body shape, times bulimic behavior that does not occur only during episodes of anorexia nervosa. 2 types of bulimia nervosa are recognized. 1. The purging type, in which vomiting or doses of laxatives are used during the current episode, and 2. The non-purging type, in which fasting or excessive exercise, but not purging, is used to prevent weight gain. 4.3.7 Impact of bulimia. The process of binging and purging can have all sorts of side effects on the rest of the body. Bulimia sufferers often have puffy cheeks, a bit like those of a chipmunk. That is, because vomiting swells the parotid glands in the lower jaw. Their tooth enamel can often decay because of the acid that they bring up when vomiting. You might also notice little calluses on the back of their hands, caused by the rubbing against the upper teeth while sticking their fingers down their throats to make themselves sick. Bulimia sufferers also have problems with their digestive tract, dehydration, and nutritional balances, and anxiety, depression, and sleep disturbance. 4.3.8 Binge eating. It is characterized by episodes of binging without the use of compensatory behaviors such as purging that are seen in bulimia nervosa. 2 common patterns characterize binge eating: compulsively snacking over long intervals, such as all day at work or all evening in front of the computer or television, or a consumption of large amounts of food at one time beyond the requirements to satisfy normal hunger. Binge eating disorder often leads to problems with weight regulation and sometimes obesity. In clinical practice, it is difficult to distinguish between a binge eating disorder and non-purging bulimia nervosa. Some studies found that binge eating women experienced more negative affect, depression, and anxiety. This suggests that treatment approaches should focus on helping binge eaters learn to cope more adaptively with poor mood. In addition to mood, situational and cognitive factors often play important roles in binge eating. 4.3.9 Triggers of binge eating, times particular stressful situations, times particular upsetting thoughts, times feeling guilt about something one has done, times feeling socially isolated or excluded, times worries about responsibilities, problems, or the future, times boredom. 4.4 Causes of eating disorders. There is no single theory that can explain why people experience anorexia and bulimia. There are many biological, psychodynamic, family, and sociocultural theories that, when combined, can provide some understanding of what is happening. The theories can lay the foundation for the types of treatment the person might receive, but as yet there is no scientific explanation of why people suffer from eating disorders. 4.4.1 Biological theories. Some theories have suggested that anorexia is caused by damage to various parts of the hypothalamus, the part of the brain that helps balance, monitors bodily functions, and control the endocrine system via the pituitary gland. The endocrine system consists of glands such as the hypothalamus, the pituitary, and the adrenal glands. Glands communicate with each other through chemicals called hormones. To understand the development and maintenance of eating disorders, researchers have developed the concept of the weight set point. In experiments with laboratory rats, they located to different areas in the hypothalamus that control eating. The lateral hypothalamus, LH, produces hunger when it is activated. Even when a laboratory rat has recently been fed, it will still eat if the LH is stimulated. The ventromedial hypothalamus, VMH, reduces hunger when it is activated. When the VMH is destroyed, the laboratory rat will not stop eating and grows obese. The theory proposes that the various parts of the hypothalamus work together to create something like a weight thermostat, a weight set point that predisposes people to stay at their natural body weight. When the set point falls below a certain level, parts of the hypothalamus would also decrease the metabolic rate if a person is expending too much energy. If people exceed their set point, then another point in the hypothalamus is activated that reduces hunger and therefore reduces eating and restores the weight balance. The set point is thought to be determined by a person's genetic makeup, early eating practices, and the body's need to maintain equilibrium. The problem with these biological theories is that it is unclear whether brain dysfunction and changes in the neurotransmitters are causes or effects of the eating disorder. Some people have wondered whether genetics plays a part in the development of eating disorders.
Over the years, there have been a series of studies of twins that have tried to determine whether anorexia and bulimia are caused by nature or nurture. But with much debate and controversy regarding the research, the conclusion seems to be that genetic factors play a minimal role. According to some theorists, the distorted perception that anorexics have of their bodies might be connected to a blood flow deficiency in the anterior temporal lobes of the brain. The anterior temporal lobes interpret vision, and if there is less blood flowing there, it might explain why anorexics see themselves as a fat when they are thin. However, this alone could not cause anorexia. There must be other triggers that lead to the development of the disorder. 4.4.2 Cultural theories. Many theorists believe that pressures in Western societies are mainly responsible for the origin and maintenance of eating disorders. Between 1995 and 1997, Paul Garfinkel and David Garner examined the look of Miss America contestants and Playboy centerfold models over a 27-year period and found that average bust, waist, and hip size of the women featured in the magazine decreased significantly over this period. They also looked at articles in various women's periodicals from 1959 to 1970 and found that in the 1960s there was an average of 16 articles a year on dieting. By the 1970s, that figure had increased an average of 23 a year. Society's emphasis on appearance has historically exerted much greater pressure on women than on men. Some sociological theorists believe that this double standard of attractiveness has made women overly interested in their appearance, dieting, and body image. The idea is supported by trends in advertising that have presented and even to some extent defined a desirable male physical form that has led men to become more concerned than before about their own eating habits. The increasing preoccupation of the media and leisure world with male attractiveness seems to correlate to an increase in the number of men who now appear at clinics with eating disorders. 4.4.3 Family theories. The family functions like mini-society and can often be the starting point for the development of eating disorders. Research shows that about half of the families of people with eating disorders have a history of making big issues of thinness, food, and body image. From early childhood, food can be a powerful tool for communication between parents and children. Systems theorists are scientists and thinkers who see relationships between all sorts of systems, big or small, physical or abstract, scientific or social. Psychologists who subscribe to systems theory take the view that a family will come to set its own level of homeostasis, or balance. They suggest that the presence of someone with an eating disorder in the family is really only an expression of some pre-existing family disturbance. The family therapist Salvador Minuchin is a leading systems theorist who has suggested that an enmeshed family pattern often leads to the development of an eating disorder in one of the children. Enmeshment occurs when parent and child are overly involved in each other's lives. On the one hand, enmeshment can create affectionate, close, and loyal relationships. On the other hand, it can prevent a child or young adult from growing up and becoming independent. Adolescence can be a real crisis point for enmeshed parents and children since the young are trying to establish themselves in the grown-up and are searching for identity. It can disrupt the balance of the family. The parents might no longer feel needed, the roles need to change, and as the family seeks to regain its balance, the child is moved to take on a sick role. If the family functions to look after the sick child, the pain of growing up and many other potential conflicts are avoided. In such instances, family therapy can be used to help the family face the underlying tensions and shift the eating pattern. Anorexia is prevalent in the middle-class female children from families with high aspirations whose parents have a professional background. It is also more common in those who go on to higher education than in those leave school at the earliest opportunity. Anorexia sufferers are often A-grade students who give perfection in all they do, including the way they look. The pressure on these young women to succeed might just to be great, and it sends them into a spiral anorexia or bulimia and anxiety or depression. 4.4.4 Other possible causes. Cognitive behavioral and psychodynamic theories are derived from the increasingly popular idea that eating disorders are linked with dieting behavior. It is akin to a stimulus response mechanism. Over the years, there have been a series of studies of twins that have tried to determine whether anorexia and bulimia are caused by nature or nurture. But with much debate and controversy regarding the research, the conclusion seems to be that genetic factors play a minimal role. According to some theorists, the distorted perception that anorexics have of their bodies might be connected to a blood flow deficiency in the anterior temporal lobes of the brain. The anterior temporal lobes interpret vision, and if there is less blood flowing there, it might explain why anorexics see themselves as a fat when they are thin. However, this alone could not cause anorexia. There must be other triggers that lead to the development of the disorder. 4.4.2 Cultural theories. Many theorists believe that pressures in Western societies are mainly responsible for the origin and maintenance of eating disorders. Between 1995 and 1997, Paul Garfinkel and David Garner examined the look of Miss America contestants and Playboy centerfold models over a 27-year period and found that average bust, waist, and hip size of the women featured in the magazine decreased significantly over this period. They also looked at articles in various women's periodicals from 1959 to 1970 and found that in the 1960s there was an average of 16 articles a year on dieting. By the 1970s, that figure had increased an average of 23 a year. Society's emphasis on appearance has historically exerted much greater pressure on women than on men. Some sociological theorists believe that this double standard of attractiveness has made women overly interested in their appearance, dieting, and body image. The idea is supported by trends in advertising that have presented and even to some extent defined a desirable male physical form that has led men to become more concerned than before about their own eating habits. The increasing preoccupation of the media and leisure world with male attractiveness seems to correlate to an increase in the number of men who now appear at clinics with eating disorders. 4.4.3 Family Theories. The family functions like mini-society and can often be the starting point for the development of eating disorders. Research shows that about half of the families of people with eating disorders have a history of making big issues of thinness, food, and body image. From early childhood, food can be a powerful tool for communication between parents and children. Systems theorists are scientists and thinkers who see relationships between all sorts of systems, big or small, physical or abstract, scientific or social. Psychologists who subscribe to systems theory take the view that a family will come to set its own level of homeostasis, or balance. They suggest that the presence of someone with an eating disorder in the family is really only an expression of some pre-existing family disturbance. The family therapist Salvador Minuchin is a leading systems theorist who has suggested that an enmeshed family pattern often leads to the development of an eating disorder in one of the children. Enmeshment occurs when parent and child are overly involved in each other's lives. On the one hand, enmeshment can create affectionate, close, and loyal relationships. On the other hand, it can prevent a child or young adult from growing up and becoming independent. Adolescence can be a real crisis point for enmeshed parents and children since the young are trying to establish themselves in the grown-up and are searching for identity. It can disrupt the balance of the family. The parents might no longer feel needed, the roles need to change, and as the family seeks to regain its balance, the child is moved to take on a sick role. If the family functions to look after the sick child, the pain of growing up and many other potential conflicts are avoided. In such instances, family therapy can be used to help the family face the underlying tensions and shift the eating pattern. Anorexia is prevalent in the middle-class female children from families with high aspirations whose parents have a professional background. It is also more common in those who go on to higher education than in those leave school at the earliest opportunity. Anorexia sufferers are often A-grade students who give perfection in all they do, including the way they look. The pressure on these young women to succeed might just to be great, and it sends them into a spiral anorexia or bulimia and anxiety or depression. 4.4.4 Other possible causes. Cognitive behavioral and psychodynamic theories are derived from the increasingly popular idea that eating disorders are linked with dieting behavior. It is akin to a stimulus response mechanism.
Anorexics might be striving for perfection and so go on diets to achieve their ideal weight. When they reach this goal, they might well receive admiration from those around them. And this further reinforces their dieting behavior, and so it goes on in a vicious circle. Reward for not eating might come in the form of attention from family and friends. There might also be approval. The anorexic looks like an athlete or a supermodel and gets admired for it. For bulimia sufferers, the reinforcement might come from binging and purging, which reduce their anxious thoughts. Psychiatrist Hilde Bruch was particularly influential in cognitive and psychodynamic understandings of anorexia and bulimia. She argued that disturbed mother-child interactions lead to ego deficiencies in the child, poor sense of autonomy and control, and this causes severe perceptual and other cognitive disturbances. According to the theory, parents fail to respond to their children effectively. For instance, a child cries, and rather than trying to understand what the crying is about, the child might be tired, hungry, or scared. The parent will give food for comfort. According to Bruch, children treated this way fail to develop cohesive self. They grow up confused and not sure of when they are hungry or when they are tired. As they grow to adolescence, they need to develop an increased sense of autonomy yet become stuck because they are unable to be independent and judge their own sense of self. 4.5 Treatment of eating disorders. A wide variety of treatments have been used with eating disorders. Treatments used range from biologically based approaches involving antidepressants, anti-anxiety drugs, and appetite stimulants to psychotherapy and family therapy, based on psychodynamic principles, behavioral and cognitive behavioral therapies, and educational therapies such as nutritional education. Most of the treatment approaches use a combination of medication and behavior modification or psychotherapy. 4.5.1 The biological treatment. The biological treatments show that in 33% cases there is dropout from the treatment. This when compared to the cognitive therapy, which has only a rate of 5% dropout, 4.5 point to family treatment. Treatment includes neither biweekly nor monthly family meetings. Sometimes, friends of the client and other people can also attend the meetings. The therapist encourages the family to explore its beliefs and behaviors about the disorder and other related family issues. Therapists work in pairs or teams. The family is encouraged to do homework, tasks. The specific nature of intervention is based on the therapist's working hypothesis. 4.5.3 Cognitive behavioral treatment, weekly to biweekly therapy with cognitive therapist. The therapist focuses on interaction between thoughts, feelings, and eating behaviors. Behaviors that create and maintain thinness are negatively reinforced, reduced by the removal of anxiety. The client and therapist explore society's perception of physical attractiveness. They also examine the client's beliefs about body image. An educational component of the therapy consists of assessing dietary and physical possibilities. The client's monitoring negative automatic thoughts, keeping food diaries, and completing rating scales. 4.5.4 Psychoanalytic treatment, weekly to 5 times a week individual therapy. The therapy seeks to make the unconscious motivation as conscious motivation of disordered behaviors. It uses the relationship between the therapist and client to explore important relationships in the client's early life, as for example the one that the client had with his or her parents. 4.6 Summary. The prevalence of eating disorders appears to have increased over the past 50 years. The major eating disorders are anorexia nervosa, in which the individual seems obsessed with thinness and loses a great deal of weight. Bulimia nervosa, in which excessive quantities of food are eaten followed by purging, and binge eating, in which large quantities of food are eaten but there is no purging. Personality, family, and cultural factors play significant role in causing these disorders. Most of the treatment approaches use a combination of medication and behavior modification or psychotherapy. Most of the treatment approaches use a combination of medication and behavior modification or psychotherapy. Thank you. Subscribe to our channel for more updates, and we will see you with the next chapter.